adequate exposure, they may ask you just to challenge you, how would you handle a case in which you are not adequately exposed? So we'll give you just some tips. I'll tell you about some tricks so that you can handle cardiac MR cases if they are shown to you in an exam. So, but keep in mind, if you are being shown a cardiac MR case, it means that you are already done really well. It is just to test your skills and how you can get extra marks in that case. So this is the basic philosophy of the exam. Okay, this is my list. Let me share my screen. Candidate 1, can you see my screen?
Yes, sir.
Okay, good. Mm. The list as well. Yes. Okay, I will start by showing you the cases and then we'll move forward from it. Okay. I will show the first case.
Sir, can I ask you one question?
Yes, please.
Sir, don't you have Cyrix cases, because we can do hands-on practice on those cases to get over the software also.
Cyrus software, they usually what you are saying that you want to, because the system is different there. When I gave my exam, they told me to use cursor buttons and things like that for hovering. But
Yes, sir.
if you're in exam settings, they will make sure that it is hovering really well. Okay, if it is not, just let them know from the start. They will check that. When you will be sitting for the Viva, they will initially check that and they will ask you whether everything is going well or not. If it is not, you can always ask them to hover for you. I think that is available in um, Apple. I don't have Apple. I'm an Android person, so I don't have access to that. I think I'm sorry for that. Okay, Dr. Fozia's session was cancelled. She had an emergency due to which she could not do the session. So I'm going to replace her. So rather than canceling a session, we said let's take another session. Okay, so
Okay, thank you.
let me start. Okay, we start with this case 2. Okay, let me share the screen for you. Else, can you comment on
Sir,
that?
yeah, on the sequence there is actually regurgitation from the from the bicuspid wall back into the left atrium, and so there's a backflow of contrast into the left atrium representing mitral valve regurgitation, and I want to also see other views.
Yeah, here's a view.
Yes, there is the mitral valve appears not fully closing in the systolic in the cardiac cycle, and there is a regurgitation seen, and the left ventricle also appears enlarged. In my routine practice, I will measure the chamber and correlate with the history if the patient has any history of ischemic heart disease. and I need to also check on the other sequences. Um,
Okay.
the
So in
right
your routine practice, sorry, it will be some example will take interactive hour. So in your routine practice, how will you measure a chamber size at which level and in which phase?
there are two from the theoretical knowledge that the heart is measured in two and diastole and systole, both is measured. Yes, what I remember.
You will measure both diastole system,
And also the left ventricle myocardial width is also measured. Um,
myocardial
mm,
thickness.
yes.
Okay. What is this sequence?
This is the cine gradient echo sequence of the short axis of the left ventricle, and the left ventricle lateral wall appears thinned and not contracting in synchronously with the other walls of the left ventricle. So this is representing kinetic disorder actually due to old ischemic infarct of the left lateral wall. Um, I need to correlate with other sequences as well.
Okay. Um,
It also appears thinned out. The left lateral ventricle wall also appears thinned out as compared to the other normal walls, anterior wall and the septal wall.
okay. So if we go towards the if we if I can show you the sequences, okay. So yes, so this is the apical segments, okay, and then we are moving towards the mid segments where you
Mid
can see
and the
the
basal
muscles.
segment.
Okay.
Yes, yes,
If
sir.
you see the, can you mute yourself? Okay. When you see the myocardial muscles, papillary muscle, it means you're in the mid segment. Okay. As we go, this is the basal segments of the heart, in which you do not see any myocardial segments. Okay. And usually, what we do is we measure the ventricular diameter at the basal segment in diastole. We always do that in diastole. The measurements we take mostly we take in diastole and we of the ventricles, and we do that in the basal segment usually. Okay, so this is the standard landmark for measuring ventricle. In the short axis sequence, we do it in the short axis sequence, and we do it in the diastolic phase and we measure it. We usually also see how the slice was taken and we measure at the plane of the slice taken. And this is how we take the standard measurements of the ventricles in diastole. Okay, the standard measurements vary between male and female. Usually, if it is around 5.8 to 6, if it is more than that centimeter, then it means it is dilated ventricle. Okay, so this is for that. And yes, you're correct. Your description is really good. There is some hypokinesia for other people as well. If I show you the cine, if you can see, we usually put a something in the center. If you see, all the walls are moving towards that cursor, okay, except for the lateral wall. Lateral wall is not much moving towards the center, okay. So it means there is some uh, decreased movement of the wall. It is called hypokinesia. And if you can see, this is the septal wall, this is the lateral wall. We call this the inferior wall, and we call this the anterior wall. Always remember the heart is placed in the chest cavity in oblique position. So its walls are different. Okay. So this is the anterior wall, this is septal wall, this is lateral wall, and this is inferior wall. And if you see the septal wall, it is thickening and then it is thinning in a normal fashion. This is the normal movement. This is how much it should thicken and it should thin. So if you look at the lateral wall, it is not thickening and thinning in that fashion. So there is something wrong with that. Okay. And she rightly said the heart seems to be dilated as well. So her description is really good, but it is slightly earlier. She should have waited for the post-gadolinium or late contrast sequences, because it can be due to, rather than an old infarct, it could be due to a stunned myocardium. Okay, we'll talk about it later. What is the difference between a stunned myocardium and an hibernating myocardium? It is usually a burning question for FRCR 2A exam as well. So we'll come to that thing later. But it was just to review your what you were saying. It was slightly an immature statement because you should have waited for the post-contrast sequences to make your statement complete. Okay. For this, it is good that there is some. It is really good and excellent that you have picked up hypokinesia. You have picked up wall motion abnormality of the heart, but it is slightly immature to call it as old infarct just straight away. You need to look at all the sequences first before calling it something. Okay, so most important sequence, which I call it the cheat sequence in cardiac MRI, is the late gadolinium sequence. And okay, let's go for the late gadolinium sequence. Okay, candidate one,
Yes,
can
sir.
you unmute yourself? Yes, please.
Yes, sir.
So this is
So
the late gadolinium sequence. Yes, what do you think?
the late gadolinium sequence on the short axis shows there is a abnormal increase enhancement in the subendocardial portion of the left lateral wall, representing endocardial infarct is established. Acute chronic endocardial infarct of the left lateral wall.
Okay, good, excellent. Can you mute yourself?
Yes.
So this description is good. Okay, so the diagnosis was correct as well. Okay, but here the approach is important. Even if your diagnosis is correct, I might fail this student on her premature answer previously. If she completes her answer like that, like she did now, she will definitely get a pass. But her previous approach was not right. Okay, you should not give premature statements. It shows that your approach is not right. It shows that you have guessed it, something like that. And there can be other possibilities due to hypokinesia of the heart wall. Okay, it can be due to stunned myocardium, it can be due to hibernating myocardium, or it can be due to a myocardial infarction. Okay, myocardial infarction is not only one of the cause of the dyskinetic movement of the heart wall. It can be due to other causes as well. So take your time, see all the images, see all the important images, and then give your diagnosis. Just don't rush towards it. Okay, it gives a very false impression. Even if your main diagnosis might be correct, but examiner might fail you because your approach is not right. So here, taking a safe approach in FRCR exam is more important than giving a right diagnosis. You should keep this thing in mind. So safe approach is the most important thing rather than giving a right diagnosis. So if you have a safe approach, even if your diagnosis is wrong, you may pass it. Okay, but if you have an unsafe approach and your diagnosis is correct, they will fail you. And I have heard of a candidate who gave all the right diagnosis, and they shook their hands with him as well. Previously, it used to be in person, exam was in person, and still they failed him because his approach was not right. So approach towards a case is really important. Okay, and see all the images, all the available images, and then go for your diagnosis or all the essential images. And you should ask for these images. So is in FOC case, you should ask for late gadolinium sequence. It is the diagnosis is not complete if you ask for it. Okay. So good, excellent diagnosis, but you should ask for these sequences, okay, before giving a diagnosis like that. So the other thing is important to mention is the left ventricle was dilated. There is an infarction. The cardiac function is reduced as well. So this is leading to a ischemic cardiomyopathy. Okay, so in case of infarction, and then there is dilatation of the heart as well as there is reduced cardiac function, it will lead to a ischemic cardiomyopathy. Basically, it is a dilated cardiomyopathy. We divide dilated cardiomyopathy into ischemic dilated cardiomyopathy and non-ischemic dilated cardiomyopathy. But this is the most common cause of dilated cardiomyopathy is ischemia, and sometimes we label it separately as ischemic cardiomyopathy and then the dilated cardiomyopathy apart from ischemia. So this is a case of ischemic cardiomyopathy. Okay, and very well picked. I won't. I was not expecting that you will pick up the regurgitation. You can see some regurgitation. It was not that much evident on the two-chamber view. This is the four-chamber view. You can see jet of contrast from the mitral valve coming from the left ventricle into the left atrium. So there is some mild mitral regurgitation and mild tricuspid regurgitation as well. So these regurgitation were present as well. Good, excellent. So well done. Now moving towards another case. I will show you one more case. Case number. Okay, can everyone, can you unmute yourself? Can you see the screen?
Yes, sir.
Okay, so this is what view?
And this is the four-chamber view
Good.
of the
Okay. Is there any finding?
I think there is re regurgitation. I think there is.
Okay,
Uh,
okay. What else you want to see now?
there are other sequences in the short axis view of the scenic gradient sequence, and then state sequence also, and then gadolinium. On this sequence, the heart appears normal in size, and myocardium is also normal in thickness, but I want to see on the short axis view.
Okay, so this is your short axis view. So now you see the papillary muscle, so you are in the mid myocardium.
Mid myocardium, yes.
So, and you do not see the papillary muscle, now it is the basal region of the
Basal,
myocardium.
yes.
Okay, good.
Again, sir, there is some relatively reduced movement of the posterior wall.
Okay, so we usually call it anterior and then there is inferior wall. Okay.
Inferior,
You
yes, sir,
can cause
inferior.
inferior wall posterior as well, but this is not the standard terminology. Okay, so go for the standard terminology.
Yes, sir, and also it appears relatively reduced in thickness as compared to the other walls. So there is hypokinesia as well as reduced thickness, and some signal abnormality is also detected. So I need to confirm it on the post-gadolinium late phase as well as the stir sequence.
Okay, this is the post gadolinium. No, I think it's T1 mapping. Sorry. Yes, I think this is. Yes. How would you think?
So I think this is the signal, high signal is seen on the inferior wall. So this signifies, I think, edema, but I need to confirm on the stir sequence. Suspecting acute infarct might be, but stir sequence, first I will check with the stir sequence.
This
And
is
this is the stir sequence, and it's signifies edema of the posterior wall representing acute infarct. So this is an emergency, and this patient needs to be immediately managed to revert the infarction.
okay.
I think coronary angiography and digital subtraction angiography uh, for the confirmation of infarct.
Confirmation of info.
So for the confirmation, and also cardiac markers, troponin levels to be checked.
Okay. Okay, good. Your diagnosis is correct. Again, the infarct is confirmed on the MRI, and the conventional angiograph, we do not look at the myocardium, they look at the coronaries. So you
Coronary
can
artery.
see that if you want to see, can you tell me which area which is affected, which territory?
Their posterior wall is supplied by the inferior, that can be from the right coronary artery or the left coronary artery, but it is from the in posterior, from the dominus. It is depending upon the dominus. The artery supplied, I don't, intraventricular artery. I didn't remember the name correctly.
No,
Um,
if you don't remember the name, don't make blunders. Okay, you're making
oh,
blunders all around. You're giving the examiner opportunity to fail you. Okay, so if you do not know something, just give a statement. I'm sorry, I do not know the exact territory, but I will check with my colleague, a cardiac imaging specialist colleague, and I will ask him, and then I will convey to you. So don't give a false information. Okay, so they are examiners, they are checking you. Okay, so even if you have given me in both cases the correct diagnosis, but as examiner, I might fail you because you're in the first case the approach was not right. In the second case, you are making blunders and you're not taking opinion. So in FRCR setting, the main focus is to be a safe radiologist rather than a correct radiologist, because a safe radiologist might save the patient's life. And you're advising an investigation, you don't know what it is looking at. So this needs to be corrected. I'm really happy that you gave Viva like this so that all the other people can learn from that as well. So you should know why you are advising a further investigation. So they will ask you why you want to advise a conventional, or you said digital subtraction, or nowadays all the conventional digital subtraction angiographies in UK at least. Why are you suggesting a next investigation? So they would know clinically this is an acute MI. Okay, so if you want to say, okay, if you want to see the coronaries and things like, then this is visible. If you're saying they want to confirm the MI, so they cannot confirm it. They will only see the coronaries. Okay, let me show
so
it.
for therapeutic purpose to remove the thrombus if it is present.
Yeah, so this is a good answer. Rather than saying that, so can you see any myocardium there?
No, 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 sir. Only coronary arteries are visible on
Only
the
coronary
angiogram.
arteries. So to confirm the diagnosis, they cannot confirm there is myocardial infarction. They cannot confirm that on
Sir,
angiography.
I said this is an emergency, so the patient needs to have an angiogram for therapeutic purpose. I mean that.
You meant that, but you said
Yes.
something else. So this is really important. So you should talk what you are thinking. Okay. So as an if you give Viva, you're anxious and you may talk certain things which you don't mean, but an examiner will count these things. So you need
Okay.
to take care of your anxiety. You need to make sure that you're not anxious on that day. You need to make sure you do not say things that you do not interpret. And you talked about an intraventricular artery. There is no intraventricular artery. There is posterior descending artery or anterior descending arteries and things like that. And if there is an infarction, like initially in the start, just to give you, I don't want to discourage you or anything like that, but you are a very good exam scenario, exam candidate, which usually candidates do that. They are in such an anxious state when they come for the viva, and they will do certain things, they will say certain things which are they're not supposed to say. So the good thing would be that to learn from that, give some vivas to yourself, to other people, so that you calm yourself down and you learn from your mistakes and you do not say things that you do not mean to say. Okay,
Yes, sir.
so this is an important, otherwise you will be marked negatively in the exam and you will fail the exam, although your diagnosis will be correct, everything will be correct, and you will be saying that I did a very good viva, but examiner, if I am the examiner, I might fail you on these things, that she is not safe, she is not checking with someone else, she is giving statements. So if I am a clinician, I will be shocked. So these things are really important for an exam point of view. it is not a bad thing that to say that I do not know. This is not a bad thing at all. This is considered a good thing. And most of the senior people I've seen here, they say that thing. I'm sorry, I don't know about what is the diagnosis of this case. But I think this cannot be this cannot be this cannot be this. Can this be this thing? So this is a really important UK culture here. So you
Yes.
may not know the exact diagnosis, but your approach should be safe. You should not the in here the health system is all government system, so everything is government based. So if you would advise an unnecessary investigation, if you do not know why you are advising an investigation, it will they will mark you low for that you are advising extra investigations, you are increasing our budget for no reason at all. So these kind of things are really important. Okay, so good excellent diagnosis, but you need to make sure that you need to be viva smart. You need to make sure that you have viva skills as well. So theoretical knowledge is not enough. You need to have certain viva skills. You need to know how to approach a case for practical purposes. You need to understand how you need to know your limitations as well. As a radiologist, if you show me an MSK case, I might comment on that this is likely a benign lesion or this is likely an aggressive lesion, malignant looking lesion, but I may not know the exact diagnosis and I will say this thing. I will refer to my MSK specialist radiologist and will ask for his opinion regarding that. But this looks like a benign or a malignant lesion to me. So this thing is really important, and they're looking for these things. So they might show you some difficult cases where you're not strong enough, and they will like to see how you approach these cases. So if you give false diagnosis, if you talk about things that you do not know, so it means that you are a person who can misinterpret things. So it will go against you. So in these kind of cases, which they may show you a contrast enhanced ultrasound, they might show you a PET CT scan, they might show you anything like this. So if you are not sure about something, okay, just basic thing is to focus on anatomy. Okay, and one more thing, they might give you clues in FRCR exams. When the examiner gives you a clue, it is a very valid clue. So I gave you a clue. You talked about that this wall is the posterior. I said no. The standard terminology is inferior. Please stick to that. And continuously you said posterior, posterior, posterior. I can understand that, because if someone who's giving a viva, he's a very stressful state. So you are doing a selective listening kind of thing. So you may not listen everything that examiner is saying. You are in your own anxious state, and so you are not listening to examiner. So in efforts, your examiner will give you very good clues. And if you listen to the examiner, you need to make sure that you follow that clue if you want to reach a good diagnosis and proper description. So I gave you a clue that don't use this terminology. This is not a standard. Some people use it, but this is not a standard. This is not an AHA terminology. So go for the inferior. But still, you continuously use that. So it shows that you are anxious, and it can happen. It can naturally happen. I can totally understand that, but you need to go out of that phase. Okay, if you want to score high in the viva or other things, you need to go out of that phase, and to how to eliminate that thing is to give more vivas.
Yes, sir.
Okay, so well done, excellent candidate one, you did really well. You gave some really good diagnosis, but I want you to tune your approach a bit. Okay, excellent, excellent candidate
Thank you.
one.
Thank you, sir. Thank you very much.
Okay, so I had a question to show some sequences. Okay, I'll talk about that. Talk about sequences. Candidate 2, are you with me?
Yes, sir.
Okay, good. Um, Let me share my presentation. It will going to be a kind of a teaching viva. So I will show some cases, then I will talk about certain things, then I will show some cases, and then I will talk about certain things. So it will be go around like that. Okay. So as already mentioned, so heart is obliquely placed, so we have different views. Okay, so we have a short axis view, which is the true short axis or axial sequence of the heart, and you can see the right and left ventricle in that. Okay, or we call a short axis view, we call it a true true axial image or a short axis view. Then we have the horizontal long axis view, which we usually call it the four chamber view. You can see all the four chambers. It is obliquely done, okay, so that you can see the true like long axis of the heart. It is not the long axis of the body. Then we have a two chamber view, okay, which we use the term two chamber view for the left ventricle two chambers, okay. If you are doing a two chamber right ventricle, which we rarely do, we do it for ARVC, arrhythmogenic right ventricular cardiomyopathy, then we will label it specifically the two chamber right ventricle view. Usually the two chamber view means, or it is a left ventricular view, okay. These are the main views. Then we do a three chamber view as well, okay. So cardiac MRI had different sequences. I think Dr. Bushra asked it. So initially we do axial haste images, which is for the anatomy. Then there are standard views, four chamber views, three chamber views, and two chamber views, and short axis view. These are the standard views. We do these sequences in all the images, okay. Then we have edema sequences. We can do T2 fat set or T2 star sequences. We call them myocardial edema sequences, okay. So they can tell you if edema is present, as rightly said by candidate one, it means that it is an acute myocardial infarction rather than a chronic myocardial infarction. So I've shown you two cases. First case was of a chronic myocardial infarction, and the second case was of an acute myocardial infarction. Okay, so if edema is present, it is going towards an acute myocardial infarction. The other thing is the post-contrast sequences. The most interesting and I call it the most important sequence in cardiac MRI, especially in myocardial infarction and cardiomyopathies, is the post-contrast sequence. And we have two post-contrast sequence, early and late. In early sequence, we look at only two things. We look at the thrombus, or we look at the microvascular invasion. If microvascular invasion looks hypointense, I will show you these things. If microvascular invasion is present, it means it is also an acute MI. If it is absent, then it's okay. In late gadolinium sequence is the most important sequence, and we look at the enhancement pattern in late gadolinium sequence. Okay, so this is the enhancement pattern in late gadolinium sequence. So we can have an ischemic pattern and non-ischemic pattern. Okay? So ischemic pattern is subendocardial, okay, and it spreads towards the towards the epicardium. Okay, so it can be a subendocardial one only like this. It can be a transmural involving the whole wall, and it can be a focal transmural as well. So this is an ischemic pattern of enhancement. So for non-ischemic, mid-wall enhancement usually is the non-ischemic one. Okay, so or any enhancement which is global, and a subendocardial enhancement which is global, it also comes in non-ischemic. Okay, so ischemic environment is the subendocardial or a transmural enhancement. So anything that touches the endocardium in a vascular territory, I will show you the vascular territories as well. So it means it is an ischemic pattern of enhancement. Okay, so if you know ischemic, non-ischemic is opposite of that. Any mid-wall or epicardial enhancement is non-ischemic enhancement. Okay, so this is the cheat code for the cardiac MRI. So the main important sequence is the late gadolinium enhancement sequence. Okay, if it is positive, so we need to look at whether this is ischemic enhancement or a non-ischemic enhancement. If there is ischemic enhancement, then we need to look at whether it is an acute or it is a chronic one. Okay, things like that. So if it is you think it is not acute, okay, then you see whether the volume of the ventricles is increased and function is decreased. If both are present, then it is a dilated cardiomyopathy. Okay, so it can be ischemic due to ischemia or non-ischemic dilated cardiomyopathy. Okay, so this is the main sequences. Okay, so talking about how much enhancement is really important technically. So we usually divide it into two things. These are four patterns. So microinfarction, 25 to 50%, 50 to 75%, and 100%. Okay. Usually we divide if it is less than 50% or if it is more than 50%. So these two, less than 50%, these two, more than 50%. If it is more than 50%, then we call that this is a kind of a non-viable myocardium. So there will be no use of doing that uh, catheter angiography because it is non-viable. It is more dead. There are more dead tissue in that myocardium, so there will be no use of doing that catheter angiography. Okay, so if it is more than 50% enhancement on the post-contrast sequences. So this is the importance of the contrast enhancement and how this transmurality can change the management of the patient. Okay, so these are regarding the different segments and views that we can take. So we talked about basal segment, okay? And we say that you can see the papillary muscles in the mid segment, and this is the distal apical segment in which it is small, and you do not see the papillary muscles. You may sometimes see the ends of the papillary muscle in that as well. Okay, so usually anterior wall, this is the anterior wall, this is inferior, this is septal, and this is lateral wall. This is the normal nomenclature. Okay, so usually anterior wall is supplied by LAD. The name says LAD. So left anterior descending artery, anterior wall. Then the inferior wall here, it is supplied by the RCA, okay, right coronary artery. While the lateral wall, it is usually supplied by LCX. Okay, so the chronic infarct we saw, it was an LCX infarction. The acute infarct, which was supplying the inferior wall, it was an RCA territory infarction. Okay, it's just to give you a basic knowledge. There can be overlap of territories that they can go into septal, the anterior one, the inferior one may also go into the septal, but usually you should know the clear distinctions of that. Okay, you should be confident about that. And the dominance may change as well. This is also right, but still you should comment on the common things. Okay, so considering the distribution, this is most likely an LAD territory infarction. You will be 80% correct because the 80% the dominance is on the right side. Okay, and 10% there can be left dominance, and 10% there can be co-dominance. Okay, so go for the common descriptive terms and things like that. Okay, so this is about the supply. So this is the lateral wall, so it will be LCX territory. And this is, if you see, this is involving the anterior wall. So this is an LAD territory, and I have already shown you an RCA territory infarction. So you've seen infarction of all the territories as well. Okay, candidate 2, are you with me?
Yes, sir.
Okay, good. Now I'm moving towards a topic which is also for FRCR 2A exam as well. And you might know about it, the hibernating myocardium or stern myocardium or myocardial infarction. Okay, so candidate 2, do you have any idea about stern and hibernating myocardium?
Sir, the hibernating myocardium is a consequence of chronic ischemia as a result of severe coronary artery disease, and still there is although there is narrowing of the coronary arteries, but still it is reversible and it could benefit from revascularization. And in the stunned myocardium is an acute a consequence of acute infarction in which there is wall in which there is motion abnormality that is also reversible.
Okay, good. Excellent. I just want to reword you what you said, but excellent concept, excellent knowledge. So if there is an myocardial ischemia means decrease in blood supply of anything, okay? So it can lead into three things, okay? Either an infarction, what we call it necrosis. Okay? If you're saying something is infarcted, it means it is dead, okay? It cannot be reversible, okay? So if there is ischemia, it can have three consequences, okay? Number one is death of the myocardial tissues, which is myocardial infarction, myocardial necrosis and myocardial infarction. The second two categories are one in acute state, as candidate 2 has said, which is called stunned myocardium, okay? And the other one is in a chronic low flow state, whether there is severe disease of the coronary artery which is chronically there. So there is no infarction in that, okay? In both these cases the function is reduced, okay? There is hypokinesia in both these cases. That's why I was against the candidate 1 calling it on short axis sequence hypokinesia as old infarct, because it can be due to stunned myocardium or hibernating myocardium. So there is hypokinesia in all of these things. Okay? There is hypokinesia in myocardial infarction. There is hypokinesia in stunned myocardium. There is hypokinesia in hibernating myocardium. Okay. In myocardial infarction, there will be a late gadolinium enhancement on the late gadolinium images. Okay, so it means this is an established infarct. So it means this is myocardial infarction. The ischemia has led to infarction. Okay. In both the stunned myocardium and hibernating myocardium, there will be no myocardial late gadolinium enhancement in the delayed phase images. Both will have the normal late gadolinium enhancement. Okay, but the differentiation will be of perfusion. In stunned myocardium, the perfusion will be normal as well, while in hibernating myocardium, the perfusion will be decreased. There will be mismatch of perfusion. So this is the differentiation between myocardial infarction, stunned myocardium, and hibernating myocardium. I'll just repeat myself. In myocardial enhancement, there will be late gadolinium enhancement. In subendocardial or transmural pattern. So there will be ischemic pattern of late gadolinium enhancement. Okay. In stunned myocardium and hibernating myocardium, there will be no late gadolinium enhancement. Okay, but we will go for the perfusion. Okay. In stunned myocardium, the perfusion will be normal, and while in hibernating myocardium, the perfusion will be decreased, or you can say there will be mismatch of perfusion. So this is the differentiation between myocardial infarction, stunned myocardium, and hibernating myocardium. And okay, saying to point of the walls of the heart again. Okay. So going for the heart walls again, so there is the basal segment. You can see here, it is taken from the basal slice. Okay, so it is 4-chamber view, 2-chamber view, and this is 3-chamber view. Okay, so basal slice, it is taken from the basal slice. Okay, slice is here. Okay, you can see only part of the valves here. Okay, so this is a basal slice. You do not see any papillary muscles here. Then there is the mid segment. In the mid segment, you can see these papillary muscles here, these papillary muscles here. So you can see papillary muscles. So it is the mid segment. Then we go for the apical segment of the heart, which is the distal segment, and it is smaller in size, and you do not see usually papillary muscles or any valves here. So this is the distal or apical segment. Okay, so the distal term is also incorrect. You should use the word apical segment. So basal segment, mid segment, and apical segments. I'm not going into further detail. This is usually I call this as anterior wall. This is inferior. This is septal. This is lateral wall. But there is further subdivision. I'm not going into that. Now, usually, this is a 17 segment AHA model. This is the standard that we use for reporting. Okay, now going for the perfusion images. Like I was telling you, we do the perfusion images. Okay, so again, I will come back to it again. So candidate 2, these are images which are labeled. Can you explain them?
Sir, these are short axis cardiac MRI images with rest and stress imaging, in which I am comparing the rest and the stress images. There is a signal abnormality along the inferior and lateral walls in the stress image on the apical and mid myocardial images, and this this could represent a cardiac ischemia or edema, and I would in my routine practice look at other sequences, particularly the late gadolinium and the
Late GAD is present.
4-chamber
Late GAD is present on the same.
late GAD.
C. So you have A, B,
Yes, sir,
C.
yes.
A is the rest, A is the stress, B is rest sequence, and C is the late gadolinium enhancement sequence.
Sir. So on the late gadolinium sequence, I cannot see any area of delayed enhancement, any subendocardial or any mid myocardial region of delayed enhancement. There is there is a small focus or a signal abnormality in the mid myocardial view in the
Ignore that.
inferior. Okay. Uh, so, as in stress image, the signal abnormalities which are not showing any late phase, late gadolinium enhancement, I would consider reversible ischemia that is there. And I would correlate that with other investigations like ECG findings discussed with the cardiology team and confirm this finding with a cardiac radiologist.
Okay, good. Excellent. Excellent description. So I really liked your approach, although you didn't speak about the right terminology, but it's okay. Your concept was good. You talked about the right things. Okay, you picked up the findings. You described it well. No matter if your terminologies and things like that are incorrect, it's okay. You need to describe the concept well. If the examiner tells you that please use this terminology, then you have to change it to that terminology. Otherwise, if you are going ahead and your concept is right, examiner may or may not intervene in between. Okay, so this is a stress phase. The initial three sequences, the upper, then the middle, or the rest phase. Okay, we usually do that on a motion correction sequence, so they are in a kind of a motionally corrected because there is a motion of the diaphragm and motion of the lungs, so they are motion corrected sequences. And then there is the third one, which is the late gadolinium enhancement sequence. Okay, so you can see on the late gadolinium enhancement sequence there is no infarction. Okay, so there is no myocardial infarction. So the patient is 60-year-old male with typical acute angina symptoms. And you see there is a mismatch of the perfusion. Okay. You can see there is on stress, there is hypointense signal abnormality, which is along the septum at the basal level, basal segments. And in the mid level, it is involving the septum as well as the anterior wall, not the lateral wall, septum as well as the anterior wall. Again, on the apical segments, it is involving the septal as well as the anterior wall. Okay, and on the rest, there is no abnormality. So this is a mismatched perfusion, or this is an inducible ischemia. We call it an inducible ischemia in this case. And in this case, it really this is really beneficial. You need to highlight it to the cardiologist, really important, because they need to do an intervention here. If they delay it, if they do not do any intervention, the patient will go into a myocardial infarction. Okay, so it is a case of acute angina with inducible ischemia. Okay, so if suppose it is a similar case of acute angina, there is some hypokinesia as well, and the stress sequence, it is here, it is abnormal. If it is normal, okay, and LGE is also normal, and there is still hypokinesia. So it means this is a stunned myocardium. In case of a typical angina, a normal stress perfusion sequence, normal late gadolinium enhancement, okay, but functional abnormality. So this is a case of, then this will be a case of a stunned myocardium. Okay. Now moving towards the next case, candidate two, can you? This
Sure.
is 72-year-old female with chronic chest pain.
Okay. So these are short axis cardiac MR images of a 72 years old woman with the history of chronic chest pain, rest and stress images, and late gadolinium images. Uh, Comparing the rest and stress images, I can see that there is a signal abnormality at the lateral wall of the myocardium and of the left ventricle and on the
Sorry,
late
sorry, I'm
gadolinium images.
interrupting you.
Sir,
So this is the septal wall. This is the lateral wall. Okay.
yes, sir.
Outward from the lateral wall, you can see only lung, but from septal wall, you can see right ventricle. So this is the septal
Sir,
wall. This
septal.
is anterior. This is inferior. This is the lateral wall. Yes, please
Sir,
continue.
okay. So there is abnormality, signal abnormality in the uh, anteroseptal wall, and on the late gadolinium image, I can see that on the apical image there is apical and mid myocardial images, there is thinning of this wall, and however, I cannot see any area of delayed late gadolinium enhancement. And in my routine practice, I would also look at cine gradient images for evaluation of whether or not this has any motion abnormality, and correlate with any acute features like ECG. And I would discuss these findings. This looks like uh, an old ischemic changes or chronic infarct changes. I would discuss with the cardiology team and confirm my findings with the cardiac radiologist.
Okay. You are saying this is an old infarction. Old infarction will be visible at which image? Infarction, we talked about that. On which sequence it is?
Old infarct, uh, one is that it would not show late gadolinium enhancement,
Old
and
infarction.
chronic.
No, chronic will show. We saw a case of a
On
chronic infarction, which was the first case we were showing late gadolinium enhancement.
so
Okay. So, okay, I will correct you. Let me go back slightly. Okay, so chronic infarction, whether acute or chronic, it will always show late gadolinium enhancement. Okay, how to differentiate between acute infarct or chronic infarct? We look at edema sequence or early gadolinium sequence. Okay, so and then we came through this chart that if there is an myocardial ischemia, it will either lead to an myocardial infarction. If it is a myocardial infarction, then there will be late gadolinium enhancement. Okay, all of these things will have function abnormality. The wall motion abnormality will present in all of these sequences. Okay, but if it is a myocardial infarction, there will be enhancement or the late gadolinium sequences, whether acute or chronic. Okay, so if there is no late gadolinium enhancement, then it can be either stunned myocardium or hibernating myocardium. And we say that if there is no perfusion abnormality, it is a stunned myocardium. And if it is a chronic case, chronic low flow case with perfusion abnormality, like we saw in this case with chronic chest pain, so there is an abnormality here, which is not present in the LGE sequences. So this is again an inducible ischemia. It is very extensive inducible ischemia. It is involving both LAD and as well as RCA territories. So it is a case of hibernating myocardium. Okay. So just to repeat myself again, so hibernating myocardium will have perfusion abnormality. This is a perfusion abnormality. It is present on the stress sequence, but it is not present on the rest sequence. So it is because of that state. In case of a stress cardiac MRI, we give agents. We either give adenosine or we give regadenosin. We make a state of stress on patient while the patient is lying down. Okay, we see his ECG, we see his heart rate, we see his blood pressure. Ideally, his heart rate should increase by 10 beats per minute and his blood pressure should drop by 10 millimeter Hg. Okay, so if we see these changes, then we take the images at the point of maximum stress and we look at these images. These are called stress images. So this is in what you call it chemical induced stress, okay, pharmacological induced stress of the patient, and we take these images. So that's we call it perfusion images. Okay, so they can tell us about the inducible ischemia. Ischemia, it is not infarction. It is not the myocardial cells are not dead, okay, but they are prone to death in case of a state of stress. So we call it inducible ischemia. Okay. So it is extensive inducible ischemia in LAD and RCA territories, and it will need definitely any intervention. So it needs to be, and it is an hibernating myocardium because LGE is normal and you have perfusion abnormalities. Okay. If you didn't have perfusion abnormalities and it was an acute state, then it would have been a stunned myocardium. So these are the differences between these things. So well done, candidate two. Excellent,
thank you.
excellent. You handled the cases really well, apart from the second case, but overall you were really good. Okay, well done. And now moving
Thank you.
towards the candidate three. Candidate three, are you here with me?
Assalamu alaikum.
Walaikum salam. Okay. Open it first. Okay. Candidate 3, can you see the screen?
जी sir.
Okay, good. This is the history. A patient with chest pain with increased leukocyte, troponin is also raised, CK is raised, so cardiac enzymes are raised. So mild tricuspid regurgitation and minimal pericardial effusion, and they want to normal ECG. So they have done a cardiac MRI. So you have limited sequences. What sequence you want to look at first?
First of all, sir, I'm not a practicing MR cardiology, so apologies if I will say anything. My terminology is not right. So I think this is white blood MR imaging, and here we can see 4 cardiac chamber view. On this view, I can see that the left ventricular wall appears normal. There is slight thinning at the apex. So on cine imaging, I can see that there is a thinning of the apex. The right chamber appears normal to me, and so I will need further short axis views.
Okay. Short axis views.
As the patient has raised cardiac markers and with normal ECG, so I'm suspecting inflammatory condition of the left ventricle. So I'm just trying to look at the wall motion, and now I am trying to look at the wall motion of the heart. So here I can see that there is mid cardiac an area of increased intensity in the mid cardiac myocardium. So I need to confirm this on static images if available.
Which image, sorry? Static image.
Yeah, because I can see that there is an area of increased intensity within the myocardium. It is in the mid part. So it is global. It's involving the globally, like it is involving the lateral and anterior wall, and also the septal.
Okay.
It,
I have study images. You like to look at
okay.
them? They are marked as well.
On star imaging here, I can see again that there is edema or increased intensity involving the anterior wall. Yeah, so it is also seen on the inferior wall. So,
Good.
so
I have late gadolinium images as well.
okay.
Abnormality in that.
So on late gadolinium enhancement, I can see that there is an area of hyperintensity which is involving the lateral wall and extending to the anterolateral wall. Yeah, it is involving the anterior and lateral wall. So as it is involving the mid portion of the myocardium, so I'm suspecting non-ischemic cause in this case. Non-ischemic causes could be due to sarcoidosis or amyloidosis. So I will convey these findings to the cardiologist and first confirm these findings with my specialist cardiologist who is well versed with this cardiac MR. And if these findings are confirmed, then I will convey these findings to the cardiologist and further management accordingly.
Radiologists also report cardiac MR. So what am I saying is good. Your description is good. Your diagnosis is incorrect, but still the examiner will pass you. Okay, because your description is good. You talked about the right things. You referred the case. If you do not know about it, you referred it case for the opinion of your cardiac specialty doctor. So which is good. So basically, this is an acute settings. We told you that there is a acute rise of cardiac enzymes and things like that. So this is a case of myopericarditis. Okay, there is trace pericardial effusion as well. If you look at this sequence, you can see some trace fluid along the pericardium.
Okay.
Okay, if you look at it, it is very trace, but still it is more than the normal pericardial fluid. It is more than the normal pericardial fluid. Okay, and on study images, you can see edema in the anterior wall as well as inferior wall as well. It is extending into the pericardium as well. Here and in the late gradient sequence, you can see mid-wall and subepicardial enhancement going to the pericardium as well. So this is a myopericarditis. Considering the clinical setting, this is a myopericarditis. Sarcoidosis can also lead to myocarditis and myopericarditis as well, but that in which there is patchy enhancement rather than this kind of a enhancement. And there are also multiple other things as well. And if you are suspecting sarcoidosis, you need to look at the axial images to look for any mediastinal lymph nodes and things like that.
Okay.
So before giving a diagnosis of sarcoidosis, you will say that if there is a clinical known history of sarcoidosis, I would like to look at the mediastinal window to look at any enlarged lymph nodes, mediastinal lymph nodes. Okay.
Right.
Good. Let me show you one more case as well. So this is one of the common cases that you can see in real life as well as in exam settings in cardiac diseases. Let me see what other case I can show you. Okay. Case number 12. Okay, can you see my screen?
Still it is showing that you have started. Yeah, now I can see.
Okay, can you read the history?
Okay. 15 years old male presented with syncope on exertion. Transthoracic echo reported enlarged right cardiac chambers. No personal or family history of cardiovascular disease. Intense workout 2 hours per day, at least 5 days a week during the past 2 years. Heart rate was 45 beats per minute.
Okay. So this is the cardiac MRI.
Okay, so I've been provided with white blood 4-chamber view of the heart. So first I'm looking at the images. So here I can see that as we have noted in the history that there is enlargement of the right cardiac chamber. So here I can confirm that the size of the right ventricles appears equal or slightly less than the left ventricle. And there is slight straightening of the interventricular septum. However, it is not showing slight straightening, but there is no bowing towards the left ventricle. And there is also slight enlargement of the right atrium. Looking at the aortic, I cannot see, so I will further check rest of the images.
Okay, so this is a three-chamber view in which you can see you're talking about aorta. So this is left ventricular outflow tract, which
Yeah.
is showing you the aorta as well.
So I can see the left ventricle and the aortic valve and out aorta. So here I can see that there is slight bulge of the anterior wall of the, it may be just positional or due to motion. Bulge anterior wall of the left ventricle. So I will confirm these findings on short axis.
Okay, so here is the short axis. I also like you to comment on the straightening of the, you said that the septum is straightened.
Yeah. So in this short axis view, this is at the level of the mid cavity, as it they are cine images. So first I will go through the images.
Yes. So is there any straightening of the septum here? Or,
No, here I cannot see any straightening. And it is showing normal thickness during contraction.
okay.
So
So we look at the straightening of the septum only on the short axis view, even if you are doing a
okay,
CT scan or an MRI scan. So it
okay,
is falsely labeled as straightening of septum on the four chamber view. If you label it,
I
always have to make a short axis view, even if in CT scan. So for
okay,
a PE, in case of PE and right ventricular strain, some people call it a straightening of the septum, although they are not looking at the short axis view, which is wrong. Okay. So
okay.
good. Overall, your findings are really good. So yes, the chambers are dilated, the ventricles are dilated, right and left ventricle are dilated. You can see here as well, the left ventricle is dilated. Okay, it is
Yeah.
the two chamber view. And then in these are the post contrast sequences. Do you see any abnormality in that?
This is late get
Yes, they can.
yeah. So um there is focal in area of enhancement or hyper intensity just at the junction of the lateral and inferior wall.
Yes, septal and
Uh,
so we call
yeah.
this as a posterior or inferior right ventricular junction point. And usually you can
Okay.
have fibrosis here. It is not something, usually not pathological. In certain cases, it is pathological,
Okay.
usually not. So ignore that. Apart from that, is
Okay.
there any ischemia or anything?
No, there is no area of enhancement on in any of the walls of the left ventricle.
Okay. Okay. Good. So do you have any diagnosis in your mind?
As the patients have dilated cavity and there is no area of enhancement, so can we see any perfusion images if available?
No, there is no wall motion abnormality. So we only see perfusion in case
Okay,
of wall
only
motion.
dilated chambers,
Mhm.
and there is no wall motion abnormalities. So
Function
I
is
will
normal
try.
as well.
Okay. So dilated cardiomyopathy may be the cause in this case.
So in dilated
That may be
cardiomyopathy,
not due to ischemia, due to any other cause, as the patient is very young, it's just 15 years old male.
in dilated cardiomyopathy, if we look at our that I showed you, the function should be reduced. The patient has normal cardiac function. It is not reduced. Only dilated ventricles. So
Does the patient have any history of um, thrombosis, or does the patient have any workout? So it may be due to myocarditis.
you read the history yourself. If there is myocarditis, you would see on late gadolinium images, even chronic myocarditis, it will appear as mid-wall enhancement. So cardiac MRI is the best imaging modality for myocarditis. No other imaging modality, even echo, can diagnose myocarditis as good as cardiac MRI, because they usually diagnose myocarditis on clinical basis. But cardiac and in cardiac MRI, you can diagnose it acute as well as chronic. We have different criteria for acute and chronic. You saw a case of acute myopericarditis, but in that case, you will have certain late gadolinium enhancement.
Mm-hmm.
This is mandatory. Okay, so very good. Now is the time. If you are not reaching a diagnosis, what you can do is you can refer the case for an opinion from your fellow colleague who is a cardiac radiologist or a cardiologist for
Okay.
his or her opinion. Okay.
Uh, okay,
Yes.
I have one question. Can we have any like congenital heart disease in this case, as a patient has syncope attack during
We did
like
not see any congenital heart disease on the sequences that we were provided. There is no AST, there is no
okay,
PST. So you need to rule these things out as well.
okay,
So, so he's a young. I told you to read the history yourself. That's why, because I wanted you to concentrate on the history. So he's a patient who has no family history of cardiovascular diseases, no personal history of cardiovascular diseases. He is intense workout, 2 hours per day, at least 5 days a week. So it was very much highlighted to you, and I wanted you to read it because I wanted you to concentrate on it. Heart rate was 45 beats per minute, which is lower than
sportsman's. That's why, yeah,
yeah. So this is called athlete's heart syndrome,
yeah,
in which this is common because like I live in Liverpool, so we have a Liverpool team as well. There are sports cardiologists, and we have these kind of cases in which the athletes are come for their diagnosis, and usually they have, some of them have athlete's heart syndrome, in which there will be only dilatation of the ventricles. The cardiac function will be normal, so it is not a cardiomyopathy. So for a
okay,
cardiomyopathy, cardiac function should be deranged. Okay, so cardiac function
okay,
is normal. There are dilated ventricles, the heart rate is lower than normal. These are all the signs for the athlete's heart syndrome. They can sometimes develop some mid-wall enhancement as well in some of the cases. Okay, but
okay,
there is no signs of ischemia or anything. So it is a difficult diagnosis, but it is seen in our in UK population. It is seen, so it may or may not come in the exam, but still you should know
okay,
about these things. Okay.
okay. Thank you.
Thank you. Thank you very much. Excellent. Now, do we have the candidate four?
Yes, sir.
Okay, good. So I think we are running out of time. I will show you some cases. Okay. Okay. Let me select a case for you.